Hello there. This is Andrew Colsky with Therapy Behind the Scenes. We talk a lot about some unique areas in therapy, and we hear from therapists as well as clients about the realities of what goes on behind the scenes. How do we know how to deal with the issues you're dealing with, and how do we actually put that into practice? So today we have an expert that I'm going to call Ira Finkel. He is from Anxiety Professionals of Illinois, and he is going to talk to us in more detail in a little bit about avoidant restrictive food disorder, which is a really interesting one to me. But before we get into all that stuff, Ira, why don't you go ahead and introduce yourself to the audience?
Sure. I'm Ira Finkel. I am a licensed clinical social worker here in Illinois. I've, first started into the field working in public and private schools, saw the difficulties that children had, and saw that the need is for some more specialized treatment to help get to the underlying issues of why students are needing therapy in schools. And seeing that schools, unfortunately, given the amount of need and the lack of resources, you're doing quantitative services instead of quality services.
Mhm.
And so you end up with kids that are just in therapy in school for almost their entire duration of their schooling, and leave the school system still not fully prepared for life.
Right.
And so, at that point, I felt that, that's doing a disservice to students, but also to the world of therapy. We go into this field with, from the moment that we first design a treatment plan, that we're already supposed to be looking at discharge. And unfortunately, in the school system, that's not what's happening. So that's when I decided that, I want to go into the private sector and start helping people to get therapy, more of that in and out of therapy. Just as you would when you see a doctor or a physical therapist, you go for a specific problem or for a specific need, and you don't expect that to be lifelong. You go in to get something fixed and then move on. And that's the approach that I take with therapy. I want people to come to me with something that's specifically bothering them, get the tools that they need, work with me, and then, usually within a year, move on from therapy. Always happy to help them more than that if they need to, but I want them to feel like they don't need me in order to function.
Right, great. And ultimately that is the goal of therapy, is to get people to a place where they are self-sufficient and able and able to address excuse me, and able to address the issues they need to address. So before we dive deeper into specifics of issues here, I am curious to know what is it that got you into the therapy field in the first place, as opposed to any other field?
Yeah, great question. As I think with most therapists, we get into this field because we have a personal experience with it, whether that's us personally or someone close to us. In my case, growing up, I did have anxiety myself. I had some separation anxiety in the form that, I couldn't go away from home. And then I did have some things that didn't quite meet the diagnosis for OCD, but I had some of these rituals that we see with OCD. And so getting treatment for that, I think, really inspired me, and seeing the effect of that really inspired me to want to take that own struggle that I had and be able to apply that with others and show them that, yes, I understand how difficult this is, but we can get through this. As much as it might seem like this is forever, I'm never going to get past this.
Right, right. So basically, you yourself were a client before you became a therapist. Is that what
Correct.
I'm saying?
Yeah.
Okay. And obviously, you had success with the work that you did with your own therapist, and that helped you understand that, hey, yeah, we can actually be effective here.
Yeah, because here I am. I'm not living at home with my parents anymore. I don't have these rituals because some of these rituals involved, you know, having to say to my mom, "Good night, mom. I love you. Good night," in that specific order.
Hmm.
If I'm living on my own and I've got my own family, that's not possible to be doing that anymore. So
Right.
clearly the work that I did as a client has been effective.
Right. Right. Great. And that's great because now when you're working with your own clients, you have that deeper understanding of what they're actually going through because you've been there.
Yeah.
So you shared that you started off doing work within a school system and the challenges of and this is always a challenge for any counselor working in like a governmental organization or something like that. They have all these restrictions on what they can do and how they can do it, and funding and timing and caseload and just a whole litany of issues that it makes it difficult for them to be able to be as effective as they could be if they were able to manage their own time and their own caseload. And so eventually you go off and open your own practice. And so when you opened your own practice, what was the decision point of what areas to get into? And ultimately, I know we're going to talk about the avoidant restrictive food disorder, but how did you decide who you were going to treat?
Well, there was, after I left the school system, I did work for a group practice that was focused specifically on anxiety and anxiety disorders. And that's where I was able to get formalized training in cognitive behavioral therapy, exposure response prevention, all the things that are necessary and in order to really treat the anxiety disorders.
Mhm.
And I knew that I always knew that I wanted to treat anxiety because that was my own experience. And I felt that having lived that experience, that, for whatever reason, whether it's, I have a personal belief in God, and I felt that that was, by me going through that, God then gave me the tools to then help others.
Mhm. And and so you said something else there that's always interesting to me too, which is therapists all have to go through a schooling program. Most of us earn a master's degree of some sort. Some people get doctorate degrees in psychology and things. But the point is, the schooling that we go to in general tends to give us a lot of general background information, but I've yet to really have any conversation with anyone who says to me, "Oh, I actually learned how to do these particular therapeutic skills in school." That's not what school teaches you. And so you come out and you're still, sort of at ground zero, and every therapist has to kind of figure out for themselves what area they want to focus on and then start learning about the therapeutic techniques available for that particular field.
Right. You're right. Unfortunately, in school, we learn about generally the techniques, but not necessarily how to really apply them. Um, and so, I've always taken the approach ever since undergraduate that, I'm a lifelong learner. And that's the approach we have to take as therapists coming out of school because, yes, we've got the master's or the PhD, but we really don't know what we're doing.
Yep. Yeah. No, here I am. I've been doing this for many, many years now and picked certain areas, that I specialize in, and I continue to learn every day. I'm constantly reading new books, seeing new journal articles, looking at new studies that are going out, talking to people like yourself. I get to learn from your experiences. So it's a lifelong process for any therapist to continue to learn to improve their skills and be up on the latest evidence-based techniques.
Yeah.
So okay, so we've got an understanding of, your background, and you get to this point where eventually you open your own practice. So, how did you end up dealing with food and food disorders?
Sure. So I first started dealing with food disorders at this practice that I was at prior to. Um, and I was never interested in eating disorders. That was something that, I didn't feel like I had competency in and didn't feel like I could, really perform well in. And so the first case that I had with an eating disorder was avoidant restrictive food intake disorder. And what got me more interested in it is actually my wife is a speech language pathologist. And a lot of people don't realize that speech language pathologists, they do have training and specialty in feeding.
I didn't know that.
Exactly. Most people wouldn't. You just think it's speech and language.
Right.
But
What's
they
the
do,
connection?
right, they do feeding, they do swallowing, anything that's involving the throat, really.
Mm-hmm.
So that's kind of how I really started to get a little bit more comfortable with this diagnosis. And I think that, this diagnosis of avoidant restrictive food intake disorder, while yes, it does fall under the category of an eating disorder, I think it's very misleading because you don't treat it the way that we would treat things such as anorexia and bulimia, and the underlying, reasoning behind avoidant restrictive food intake disorder is not the same. Like I said, I am not an eating disorder therapist. That's not my area of practice. But avoidant restrictive food intake disorder involves a lot of fear. And fear is very much anxiety, and there's a lot of exposure involved to overcome fears.
Well, let me stop you for 1 second here. Can you give us an example or a definition of what exactly, when you say avoidant restrictive food intake disorder, how would somebody know what that looks like?
Sure. So what I'll do is I'll give you what the DSM categorizes it, and then what I'll do is I'll give a case example of what that looks like in real life.
Great.
So the DSM-5 TR defines it as an eating or feeding disturbance that has an apparent lack of interest in eating food or avoidance based on sensory characteristics of food, and concern about aversive consequences of eating. And that's manifested by persistent failure to meet appropriate nutritional or energy needs associated with one or more of the following: significant weight loss or failure to achieve expected weight gain or faltering growth in children, significant nutritional deficiencies, dependence on internal feeding or oral nutritional supplements, marked interference with psychosocial functioning. And the disturbance is not better explained by a lack of available food or associated cultural sanctioned practices. And when I talk about associated cultural sanctioned practices, I'll give the example of, for me, as an Orthodox Jew, I have restrictions as far as foods that I can eat, which is things that are kosher. So for instance, I cannot eat pork or shellfish. So my avoidance of those foods would not fall under avoidant restrictive food intake because it is a culturally sanctioned practice to avoid those foods.
Okay.
Same thing with Islam, where it's the people who follow halal. So people who follow halal, it would not fall under this category. The eating disturbance does not occur exclusively during the course of anorexia nervosa or bulimia nervosa, and there is no evidence of a disturbance in the way in which one's body weight or shape is experienced. And then the eating disturbance is not attributable to a concurrent medical condition or not better explained by another mental disorder. When the eating disturbance occurs in the context of another condition or disorder, the severity of the eating disturbance exceeds that routinely associated with the condition or disorder and warrants additional clinical attention. So that's the DSM diagnosis for it. Now, how does this look practically?
Right.
So what are some of the warning signs? There are behavioral and psychological warning signs. You might see, some of the dressing in layers to hide weight loss or stay warm, which you would see that with anorexia. You might see reports of constipation or abdominal pain, lethargy. You will see that they'll only eat certain foods or certain textures of foods. And then these next ones are a little bit more specific to avoidant restrictive food intake disorder. There's the fear of choking or vomiting. And then a fear of how that food is going to affect their body. Some of the physical signs that you might see is stomach cramps, some difficulty concentrating, dizziness, sleep problems, physical signs that would be attributed with malnutrition, actually.
Mm-hmm.
So a case example is that I had a client who, when they came to me, all they would eat was white bread and cheese. Now, physically, they looked like a healthy individual. However, they were not able to keep up the energy levels to engage in physical sports that they were participating in. And they also required vitamins and supplements in order to maintain their blood work. So physically, you would not know that there was something going on with this child. But in actuality, they required all these vitamins just to maintain a level of functioning that was not even enough to maintain their daily living.
So let me make sure that I'm getting this right. It sounds like what you're saying is that the issues that a client would have with food are based upon fear as opposed to a choice because I'm too thin, I'm too fat, I'm, whatever it may be, right?
Correct. It is a fear of how their body is going to respond to the food, not in a fear of, are they going to gain weight from it, but a fear of, are they going to choke on the food? Are they going to vomit from the food? Are they afraid that the food is going to taste bad? Are they just afraid of the feeling of that food in their mouth?
Mm-hmm.
And that's what separates it from other eating disorders.
So in your experience, any thoughts or ideas of how this starts for someone? Like, where does it come from?
So there's not always a same way that it starts. However, many times it can occur with those who do have feeding difficulties when they're younger. Some who have gastrointestinal issues, such as acid reflux, or have experienced in the past choking on something. There'll be sometimes, even I'm sure with me and you, where we'll have a food, shortly afterwards we get sick from a virus, and then we associate that food with getting sick, and then we're afraid to have that food again.
Right.
A great example of that is I have an uncle who, when he was younger, he had Captain Crunch. He got sick afterwards. He went decades without eating Captain Crunch again because he was afraid that it was going to make him sick.
So is there any truth to the thought that this food might make me sick?
There's obviously there's always going to be some foods that can make us sick, such as food poisoning, but it's the food itself is not. Obviously, there's a difference of if there's an allergy, then yes, you should be afraid of that food, but that's a normal fear. because that's something to protect you. But a fear of, if you don't have any allergy to, I know I gave the example of cheese for this other client, but if you don't have an allergy to cheese, and you're not taking a bite size that is bigger than normal, there shouldn't be a fear to it.
Mm-hmm. So then if a new client comes to you that you've never met before, is it common practice, and I'm asking this because I have not dealt with this before, is it common practice that they would be tested for food allergies at some point, or like
Yeah,
what do you
so
have to be
what you're going to
concerned
do is, you're going to first have medically rule out
about?
that there is another cause for not taking in certain foods. As explained by the diagnostic criteria, that it can't be attributable to a concurrent medical condition. So, for instance, like the allergies, or if they have digestive issues that explain why they don't take in certain foods, or if someone's lactose intolerant, that's all needs to be ruled out first to make that diagnosis of avoidant restrictive food intake disorder.
Mm-hmm. Do you run into any issues related to the client's level of understanding about foods? And what I mean by that is this. Maybe a client says, "Oh, gee, I don't want sugary things for whatever reason." Yet, because I'm thinking of a specific example here. Someone who says, "Well, I'm supposed to avoid sugar. Sugar is bad for me. My doctor told me to cut down on my sugar, so on and so forth. Therefore, I've resorted to eating a lot more apples." And then when you dig a little deeper, oh, well, where do you get your apples? Oh, I go to 7-Eleven and I get the apple dumplings they have, which is basically a bag of sugar with an apple swimming in it.
Right.
But he doesn't picture it as sugar. So if he was concerned about sugar, he would be eating a whole bunch of sugar, not knowing that he's eating sugar, and he'd be fine. So do you run into things like that, of just the education of what's actually in this cheese product versus cheese, those types of things?
Well, again, what it is with avoidant restricted food intake is they're concerned about more of the choking and how they're physically going to respond as soon as they take in the food. It's not a fear of that they're going to develop diabetes or something.
Mm-hmm.
It's an immediate fear.
Okay. So they come to you, they've got no known medical reason for their issue. You diagnose them. What do you do from there? What does treatment look like for somebody?
Treatment is going to look like psychoeducation for anxiety. Explaining how the amygdala works, how that plays into anxiety, that fight or flight response, how by avoiding these foods, you're giving into the anxiety and reinforcing that anxiety.
Mm-hmm.
And then you're going to go into engaging in exposure therapy.
Okay. Tell us more about that.
So for the exposure therapy, you're actually going to slowly introduce different foods. So you might have to start off real slow, where they just might lick the food or just put it in their mouth and spit it out. It all depends on how fearful they are of these foods.
Mm-hmm.
And you slowly build up their tolerance of different foods and reducing the fear of the foods.
Mm-hmm.
And this can actually, to me, I find it just very fun engaging in exposure therapy for this. Because, how often do you get to just engage in therapy where you're just eating food?
This is true. This is true. Um, so how, going through that, what would you say is sort of the type of success rate that people could expect if they came for therapy because they had avoidant restrictive food disorder? Can they be helped for sure? Can they be cured? Can they learn to tolerate? What is expected from treatment?
Um, I'd say that expected for treatment is that, you know, you're not going to be cured. It's going to go into remission. So meaning that practically it's going to seem like it's cured, but it could always flare back up.
Mm-hmm.
But it's certainly something that can be overcome.
So, so somebody came in originally, let me see if I get this right, and they had a concern about um, eating apples because the texture, they were afraid they weren't going to be able to swallow it and it would get stuck in their throat.
Mhm.
And you do the work with them, and eventually they get past that and they're able to eat apples and they're doing fine. And then, I don't know, 2 years pass, and out of the blue, now they're concerned about eating red meat again because they might choke on it or something. Do you see things like that where some totally different food will come up later
Well,
because of the same
so
problem?
it's usually not just one food at a time. It's usually that they'll only eat 2 or 3 foods and everything else is avoided.
Oh,
So you're doing exposure therapy of a lot of different foods. So a client had come to me, the parents brought them in, um, and the parents had tried to treat this through very well-meaning intentions, but mixing and sneaking different foods in to the
mhm.
client's meals. Um, this individual, he was 9 years old. Very hard to sneak things in to a 9-year-old. They can pick up on that. And so this actually ended up causing a lack of trust between the client and his parents. And so then you're getting a decrease in the quality of the parent-child relationship. So this ends up not being just, avoidant restrictive food intake problem. This also becomes, a relationship problem. Um, and certainly, it's understandable the parents taking this approach,
Mhm.
very well intentioned, but you know, kids are smarter than we think they are.
Yeah. Well, that leads into another question that I had for you, which is, so are there specific things that, and I guess now we're talking about parents or loved ones of someone who's dealing with this disorder. Are there things that they should or things that they should not do? For example, like in OCD, when I'm working with OCD patients, if their compulsion is to wash their hands a lot, I tell the parents forcing the child not to wash their hands is not going to be helpful. So, what about in this case? Things that parents or loved ones should or shouldn't do?
Yeah, so what you're describing is along the lines of supportive parenting for anxious childhood emotions.
Mhm.
That's something that you would also do with avoidant restrictive food intake disorder. Um, you're not going to force them to take in new foods. Um, you're going to work with the therapist and have it be child and therapist directed for the foods to take in.
Mhm. So, so if your child had a concern about eating cheese, let's say, you mean it's not going to work if I take everything out of the house and I say you have cheese to eat, and if you don't eat it, you're just going to go hungry?
That's not going to work.
Okay, just checking because
Yeah.
would be one of the potential thoughts out there that I want people to understand that that's not effective, nor is it helpful.
Yeah, that's not going to work.
So what about, you mentioned that, in this particular example you were giving, that you could end up eroding trust between the parents and the child. What about in general, when you see a patient who comes in for this, do they typically have any other co-occurring disorders, or do you sometimes see a certain co-occurring disorder, happening?
I usually will see that there is some anxiety going on in other areas. Um, so usually they might have some social anxiety or some generalized anxiety. But yeah, it's usually from my experience, and again, I can only speak from what I have treated, is that there usually is some other co-occurring disorder.
Mhm. Okay. And do you treat them all at the same time? Do you treat one first? What is your approach?
Well, it depends, I think, on the severity. What is the primary concern at the moment? And can treating one of them help the other? So, for instance, with where the relationship between the child and the parent was not great, by having the parent no longer sneak food in and have the parent be a part of these exposures, it actually helped and rebuilt that trust between the child and the parent.
Mhm.
So we weren't working specifically on, PCIT, which is parent-child interaction therapy, but that is, we did end up building that trust and increasing the relationship between the child and the parents.
Mhm. Okay.
And then, after the symptoms of avoidant restrictive food intake disorder went into remission, I did continue working with this client because, I did find that, as I said, that there was some other anxieties. This child had some social anxieties, and we were able to work on those, but he was able to apply that psychoeducation from the exposures with food to the social anxiety. So it was easier to then treat the social anxiety because there was already, that psychoeducation piece that he already understood.
Right. Right. So, you talk about the use of exposure therapy, and obviously, people who listen to this podcast have heard probably many issues that I've done related to obsessive compulsive disorder. And so I'm curious, because they both use exposure therapy as one of the treatments. Do you ever find patients who also have OCD when they're dealing with avoidant restrictive food intake?
I have yet to come across that, um, but I I can almost guarantee that it is out there.
Hmm. Okay, yeah, no, it's really interesting. So, the concept of exposure therapy and how it is used in various different anxiety disorders, phobias, OCD, these types of things. It all comes back to what you were saying before. You've got this element of this fear-based background, and um, sort of the best way to solve your fears is to approach them head on and realize that they're not what you think they are.
Right.
Um, so, um, is there sort of an average age that mostly is the client base that comes in, or can it be people of any age?
For avoiding restricted food intake or just in general?
No, the avoidant restrictive food intake.
Avoiding restricted food intake usually occurs more with children.
So elementary school, middle school, any particular
Uh,
age range?
Usually again, I'm speaking from my own experience.
Yeah.
But it's usually with, early childhood. And that's usually when it develops. It
Okay.
develops during infancy or early childhood, but it can persist into adulthood, and it could develop at any age.
Mhm. And again, in your experience, do you tend to see more male, more female, evenly distributed?
I have seen it more with male.
Really?
Yeah. But I do know that that's not, as with most eating disorders, that's not usually the case. But that could also be, I know that there is some question about, diagnosing eating disorders as a whole when it comes to both sexes,
Mm-hmm.
that there is some discrepancy in that.
Right, right. So, and I realize there's not necessarily a good answer to this question, but in your experience, if somebody came in for treatment for avoidant restrictive food intake, um, could you give an estimate from your experience about how much time does it take for a client to get from beginning to at least a place where they're becoming comfortable with the food and not having so much distress about it?
Yeah, so again, there's no real concrete answer to that.
Right.
But I do know that typically using cognitive behavioral therapy for avoidant restrictive food intake disorder consists of between 20 to 30 sessions. For me, in my practice, I like to get clients to, in general, not just with avoidant restrictive food intake disorder, just in general, I like to get clients to be feeling good to go without me
Mhm.
in 6 to 9 months.
Okay. So when you say 20 to 30 sessions, and the reason I'm asking this is because I get these questions about OCD. Do you normally see clients like once a week, several times a week?
I,
What does that look like?
yeah, I always like to start off with once a week. Um, if I'm seeing that once a week is not enough, or if clients are struggling to engage in the homework and need more accountability, then I will increase to more than once a week. Once we're starting to look at 3 times a week, then I'm starting to question whether a higher level of care is needed.
Mhm.
But I always start off with once a week.
Okay. Well, I've got two more questions that I want to make sure I ask, which is, um, hang on, what was my first question here? Well, let me ask the second question first. Um, are there medications that people can take, do take, might take? Like with OCD, a lot of people don't need medication at all, but some of them benefit from adding medication to therapy. Is it similar in this case?
Yeah, it's a lot of times with therapy, you want to take the approach, or not you. I like to take the approach of, let's first try therapy. If we're stuck and therapy is just not getting us the help, then we might want to consider introducing medication to kind of get us over that hump, and then the therapy can be helpful.
Mm-hmm. Mm-hmm.
But I do know that I've had clients with avoidant restrictive food intake disorder that have not needed medication.
Okay. Yeah. So it really comes down to case by case, you know, basis.
Yeah, and I know that that can be a frustrating answer, because we all like to have concrete answers for things. Unfortunately, in therapy, there's not a lot of concrete answers. It's
Mhm.
not, it's not this is how it's going to go. It's not a 1+1. It's case by case, and that's can be a frustrating thing. But unfortunately, that's just the way that it is.
Yeah. So the work that you do you do telehealth, in office, both? How do you practice?
Right now, I practice via telehealth.
Mhm.
Plan is to then transition to doing a combination of telehealth and in office. We're looking at a timeline of 6 months to a year to doing in office. But
Mhm.
right now, I'm doing just telehealth.
And do you find any drawbacks to that or any positives to it? Like for me, I find a lot of positives to telehealth for OCD, but what do you experience?
I actually find that there's a lot of positives to it. And I think a lot of it for me is, I gear a lot of my time for clients to after school hours.
Mhm.
Um, so, a lot of times that's very helpful when it comes to kids and when it comes to even parents for when I'm doing parent coaching.
Right, right. Yeah, I agree with you. I find a lot of the similar types of benefits, as well as the fact that, with OCD, if the client has fears about something in their home, well, they can physically be in their home while they're doing therapy. So it,
Right.
it works out well.
Now certainly, with treating certain things, doing telehealth, it's not going to be too great. With kids that are younger than 8, I do a case by case basis because usually when they're that young, they can't necessarily tolerate being in front of a screen.
Yeah.
Um, and then also in the case of like selective mutism,
Mhm.
you do need to have some in-person interaction so that they can not necessarily speak to you, but write something down to then communicate.
Right.
Uh, especially telehealth, and you're dealing with selective mutism, that's going to be difficult.
Yeah. No, there's definitely cases where in office is much more beneficial for sure. Um, but again, like I say, just for me, for the OCD work that I do, I find telehealth is the preferred method for me anyway. I remembered my other question for you. So we were talking about typically starting off with weekly sessions with a client. Would a client expect to have any homework assignments between sessions?
Yes. Um, they should expect to have homework when they're working with me, because I, when I'm approaching therapy, there is concrete goals that we're going to hit. And the reason I do that is because I want you to be able to see the progress that you're making. And so that there's accountability, not just for the client, but accountability on my end.
Hmm.
Because also, oftentimes, and something that I find very frustrating in this field is when therapists see clients for years on end. And unfortunately, a lot of the general public views therapy in that way. And I don't view therapy that way. I view therapy as you're coming to me for treatment. Let's get you that treatment and get you on your way.
Hmm. Yeah.
So there is going to be homework. I don't tell kids that this is homework because they associate homework with school and writing things down. Homework for me is not, you're not going to be writing things down necessarily, unless we're dealing with things such as perfectionism when it comes to writing things and they're erasing and rewriting. Then, yeah, you're going to have written things.
Right.
But homework is generally not a written assignment.
Yeah, I was thinking to myself as I said the word homework originally, here we are, we've got someone who used to work in the school system, you working with kids, the kid sees an adult, they hear the word homework, they freak out, and now
Like,
the
I'm out.
is
I'm
are going to
out.
be a test. So, yeah, I've got to come up with a better word myself for the homework because it's not homework the way we traditionally think about homework. It's skills development, it's practicing, you know.
Yeah, I tell the kids, we're gonna practice doing this over the week.
Right, right. That's probably a good term to use. So, okay, so then how about if someone is watching this podcast, they think that they might be dealing with this, or they have a kid who might be dealing with this, and they're looking for someone who's knowledgeable like yourself, how do they get in touch with you?
So they can get in touch with me either by going to my website, which is anxietyprofessionalsofillinois.com. They can call me at 773-219-1718, or they can email me at Ira Finkel, that's IRAFINKEL, at anxietyprofessionals.com. I'm sorry, anxietyprofessionalsofillinois.com.
Okay. And so you work only in the state of Illinois?
Yes, I work only in the state of Illinois at this time. Unfortunately, when it comes to social work, there is no reciprocity between states, and there's not something like with psychologists where they have psych pact that can deal with multiple states.
Yeah, yeah. Well, Illinois is a pretty big state. I bet there's plenty of plenty of work to be done there alone.
Yes, there is.
So,
I am hoping, though, at some point in the future to then be able to work in some additional states. But right now, we're just in Illinois.
right, right. Well, it sounds like you're doing some great work. It's certainly an area that most therapists probably have never dealt with and wouldn't know where to begin. So when people, you know, are seeking therapy, they need to find someone like yourself who knows the area so that you can help them effectively. And that's why we do this, you know, therapy behind the scenes. What goes on behind the scenes? How do we actually treat this stuff? What's really happening with you? So I appreciate you taking the time out of your day to come and join us and share all this wonderful information. I know I've learned a lot from you. I'm sure the audience is learning a lot as well. And you know, hopefully we can have you back on later on when you've got some more things to share with us. And with that, you know, I encourage people to feel free to reach out to you if they have some questions or concerns, or they think that you can help them with something. You're a great resource. So thank you for joining us.
Well, thank you for having me, and I would love to come again in the future.
Great. All right. Well, you have a great day now.
Thank you, you too.